The respiratory form of anthrax is considered as the most fatal reported and can also lead to fatal septicemia. A rare case of inhalation anthrax acquired naturally by a 65-year-old man living in South Khorasan was reported. This underlies the challenges of working on an anthrax case when no exact source of infection exists.
Anthrax is an extremely rare infectious disease caused by a resilient spore-forming bacterium, Bacillus anthracis. These are rod-shaped, non-motile bacteria that identify gram-positive after a gram stain is carried out. Anthrax is spread to humans through contact with animals and is therefore said to be a zoonotic disease, although humans can also contract this disease by consuming contaminated animal products. There are 4 types of anthrax, namely inhalation anthrax, gastrointestinal anthrax, injection anthrax, and cutaneous anthrax. Of these, cutaneous anthrax is the most common and least dangerous, whereas inhalation anthrax is the rarest and deadliest, tending to display complex and uncommon symptoms.
My daddy lived alone 3 months prior to his hospitalization because my mommy passed away. We lived on a farm with sheep and goats, however they were always healthy, so they never posed a threat to our well-being. My father also suffered with COPD, so when his inhalation anthrax symptoms started showing, we as a family never paid much mind to it because we just thought it was his COPD acting up again. However, my daddy's symptoms started worsening a week before we decided to take him to the hospital, still thinking it was just his COPD. I remember my father telling me that he still felt sick, despite the treatment and the antibiotics he was receiving. Thus, the doctors referred him to the medical center of the province, where he was treated by various doctors such as Dr. Fakil and Dr. Smith.
The patient came to the medical center with a fever, dyspnea, pus-like non-bloody sputum, anorexia, as well as myalgia. Upon first examination, his blood pressure was 120/80, respiratory rate of 24 breaths per minute, and a pulse rate of 90 beats per minute, which indicated a normal functioning. The patient had no skin rash, ulcer, or necrosis in his face or arms and showed no symptoms of icterus. We performed a lung oscillation and it revealed a slightly hoarse voice. The patient had no signs of meningeal irritation and his chest X-ray appeared normal.
The patient was diagnosed with exacerbation of chronic obstructive pulmonary disease, otherwise known as COPD or pneumonia, and was treated with intravenous ceftriaxone and azithromycin. However, after 3 days of treatment, his symptoms had not improved and the patient became slightly disoriented.
My father's mental state started deteriorating, and because he was already blind, he became even more disorientated when he fell ill with anthrax, and he even forgot who I was when I came to come and visit him in hospital. He always complained about being dizzy and not knowing where he was.
We did not perform a lumbar puncture because the patient presented with no signs of meningeal irritation. Instead, blood samples were taken and sent to the laboratory for further analysis.
Upon admission of the patient, the first blood sample was drawn, and about 2 days later the results were presented to the ward. The laboratory reports indicated the presence of gram-positive streptobacilli following the analysis of the microscopic blood samples. The growth of coarse textured colonies absent of hemolysis was seen on the blood agar. Following a set of microbial, enzymatic and metabolic tests inclusive of gelatin hydrolysis, motility and sensitivity of bacteria to penicillin, amongst many others, B. anthracis was finally proposed. Collectively, these laboratory procedures took 48 hours.
We ordered a second set of chest X-rays for the patient and this revealed closed right angles, wide mediastinum and opacities in the lower region of the lung. With these new X-rays and blood analysis results, we were able to change the course of the antibiotics to ciprofloxacin and penicillin. In order to do PCR, the patient's blood and lung secretion samples were sent to the National Reference Laboratory. 2 days into his anthrax treatment, the patient developed jaundice, an increase of liver enzymes, and a decrease in hemoglobin, hematocrit, and platelets. This was concerning to us, seeing as the patient displayed no signs of obvious bleeding. These developments were then further complicated by respiratory sepsis and distress.
The patient eventually passed away a week after treatment.
The results of the blood and lung secretion analysis, as well as the results of the PCR, showed the same organism being isolated in each test. This confirmed that the type of anthrax we were dealing with was respiratory. The results also showed the sepsis that followed.
The severity and uncommonness of this case urged medical professions to report it to the Public Health Department. The department then ordered a group of healthcare workers to perform a disinfect process at the patient's rural home.
Upon arrival, we discovered and processed skin sheet that was used as flooring in the house. Typically, this would be able to explain how the patient acquired respiratory anthrax, but bacteriological samples showed no evidence of the presence of B. anthracis.
Based on recent estimations, 1.1 billion livestock and 1.83 billion people situated in agricultural regions are most at risk of being infected. There are 4 different forms of anthrax infection, namely injection, which is very rare; cutaneous, which can show symptoms 1 to 7 days after exposure and has a death rate of 20% left untreated and only 2% with treatment; gastrointestinal, which can develop 1 to 7 days after exposure, and if left untreated, more than half the cases will die. With treatment, however, the case fatality ratio decreases slightly to less than 40%. And lastly, inhalation, which takes 1 week to 2 months to show symptoms and has a death rate of 85 to 90% if left untreated, but still an alarming 45% even with treatment.
The early signs of respiratory anthrax include feeling unwell, myalgia, fatigue, fever, a dry cough, and then even more severe respiratory distress and cyanosis occurs. The patient usually dies within 1 to 2 days. In this case, the onset of symptoms was respiratory and then gradually became more severe. The patient had developed jaundice, elevated liver enzymes, and respiratory distress after 5 days. Chest X-rays are a key part of diagnosing respiratory anthrax because they are able to show mediastinal edemas. This occurs when Bacillus anthrax secretes edema factor. There is a wide range of respiratory symptoms that a patient can display, such as hilar infiltration, pleurisy, parenchymal infiltration, and of course mediastinal edema, as seen in this patient. In this case, the initial X-ray was normal because the infiltration takes a few days to be recognized. This is why the mediastinal edema was only picked up after the 3rd day. Usually in respiratory anthrax, we would notice an elevation in the number of white blood cells as well as an increased neutrophils. However, the patient displayed none of these telltale signs.
Anthrax is caused by a spore-forming bacterium known as Bacillus anthracis. It is an immobile aerobic gram-positive rod-shaped bacterium. It can be found naturally in soil and commonly affects domestic wild animals around the world. Although it is uncommon in some areas, people can get sick if they come into contact with infected animals or contaminated animal products. It is not contagious.
Blood and sputum cultures taken from the reported patient were still positive after 3 days of antibiotic therapy, which is another analysis that did not seem to point at inhalation anthrax.
Most cases of anthrax reported in Iran include cutaneous, gastrointestinal, and meningitis types. Based on the results of medical databases, this was the first respiratory anthrax over the last 3 years.
In this patient's case, the anthrax was acquired naturally, occurred without injury or risk of bacteriologist attack. The source of disease was not detected in the medical history of the patient, but it seems that the patient acquired anthrax due to the contact with the animals and their product. This may show a strong clue proposing the way that the case patient was infected. It seems that he acquired anthrax due to the adjacent contact with the animal's product, especially with wool. Soil might be the other alternative source of this contamination.
The last known case of anthrax respiratory disease acquired normally was in America in 1976. Thereafter, the involvement of respiratory anthrax has usually been due to bioterrorism or after sepsis caused by cutaneous wounds.
Although B. anthracis is an aerobic organism, it can survive in an aerobic environment because of its property of sporulation. In fact, it can survive for several years in soil, air, and water in the form of spores.
This patient was treated with a combination of antibiotics effective against Bacillus anthracis, including penicillin. The resistance to penicillin has increased, and this has reduced the use of the drug for the treatment against anthrax in many parts of the world. However, antimicrobial susceptibility testing showed that the isolate was extremely sensitive to penicillin. Another reason we chose to use penicillin was because it is used to treat cutaneous anthrax in this region, and we have had many successful cases using this drug in the past.
Livestock with anthrax generally die suddenly. Just prior to death, animals may show signs of high fever. Blood may be present around the nose, mouth, and anus of carcasses. If livestock die suddenly, even when there is no history of anthrax on the property, anthrax could potentially be the cause. We highly advise that if farmers see the signs of anthrax in their livestock, they must report to the Animal Welfare and Health.
We advise that inhalation anthrax be considered in patients with severe pulmonary illnesses, especially in endemic regions, because of its high mortality rate and also the similarity of its symptoms to lower and upper respiratory infections. Therefore, it is of utmost importance to immediately diagnose and begin successful treatment of inhalation and sepsis cases in order to give the patient the best chance of making a full recovery.
In order to prevent the contraction of anthrax, there are various precautions that can be taken, such as antibiotics and vaccines. Antibiotics such as ciprofloxacin and doxycycline can be administered to patients who have possibly been exposed to the disease but have not yet developed any symptoms. The spores responsible for anthrax usually take 1 to 6 days to become active inside the body. However, in some rare cases, the spores are able to remain inside the body for 60 days or more before becoming active and displaying visible symptoms of the disease. For this reason, antibiotics need to be taken for the duration of 60 days after exposure.
Vaccines such as AVA do not contain any bacteria and therefore cannot infect people with anthrax. It is only available to a selective group of people between the ages of 18 to 65 who could potentially be exposed to anthrax due to their job. To develop immunity against anthrax, 5 shots of anthrax vaccine should be given over 18 months, as well as annual immune strengtheners. Pregnant women and people who experienced a severe allergic reaction to a previous dose of anthrax vaccine are not eligible for the vaccine. Vaccines after possible exposure to anthrax are only given in the case of bioterrorist attacks. They would be given 3 shots of anthrax vaccine over the duration of 4 weeks, together with a 60-day course of antibiotics.
The release of anthrax has brought about negative economic costs. The government, businesses, building owners, and agricultural sectors of the economy are all affected. This has impacted the general cost categories such as loss of life, health care, damage and loss of property, evacuation and return, decontamination and decommissioning, and other indirect economic losses. The exact costs depend on the variables which are specific to the site, attack, and time of anthrax outbreaks. This disease is most common in agricultural regions of Central and South America, Sub-Saharan Africa, and many other places. The major sources acquired by humans are indirect and direct contact with infected animals. The stigma about anthrax has made people and business owners afraid of contracting this disease, even though only one form of anthrax is contagious between humans. Society would rather not interact with anyone who has been in or near anthrax outbreaks, and this has a negative impact on the business deals and the economy.
No, man, Nina.
Precautions that can be taken, such as antibiotics. 45%